Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase them all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this week's episode, we have our first CEU episode of 2026.
And our first CEU episode of our podcast studio.
I gotta get used to the button because I was ready to do it with my mouth.
Well, you could do both.
It might be redundant, though. But yes, that is true.
Yeah, well, here we are. So thank you so much to Clinically Pressed and Athletic Training Chat for helping us bring these CEUs to life. If you are interested in claiming this category A CEU, if it is one of our latest 5 episodes, it is free. But you use the same process as if it was purchasable. So you just go to their website and enroll in the course. Once you take the quiz, it automatically generates your certificate that you can submit to the BOC. If you do end up purchasing this episode or any of our older episodes, the proceeds do go to help supporting the show, and they help donate ice tubs to athletic trainers.
Yes, that's true.
Sweet. So what are we talking about today, Randy?
Today, we are going back to the upper extremity, and we will be talking about rotator cuff tendinopathy.
Okay, sweet. So what are our objectives?
So we're going to start off with, of course, anatomy of the rotator cuff and some of the related structures. We'll discuss some of the possible risk factors for rotator cuff tendinopathy and the evaluation process for suspected rotator cuff tendinopathy. And then finally, we'll kind of discuss the management of rotator cuff tendinopathy, which is actually kind of interesting because tendinopathy, you feel like you kind of have a good idea of what it's probably going to be, but the shoulder itself was kind of interesting compared to lower extremity stuff. So that'll be kind of a cool kind of aspect to dive into.
Sweet. I'm excited. I feel like when you learn it, like in the book, it's like you won't see rotator cuff stuff in anyone younger than 40.
I know, yeah.
And then you get into real life and you're like, oh, I see rotator cuff stuff all the time.
Well, you know what? And I think the hard part is, and we'll kind of it'll come up in the episode, is a lot of conditions get looped in together. Mm-hmm. Like subacromial impingement is basically like an umbrella term for rotator cuff tendinopathy, bursitis, biceps tendinopathy, rotator cuff tear has been thrown in there. So it's really hard to like find articles on one specific thing because sometimes it's looped into so many things.
That makes sense. So speaking of, if you do want a copy of Randy's references, they are on our website, which are down in the show notes below.
That's right. I was going to save that one for the anatomy, but that was the perfect time for it. References, baby.
Well, double duty. We're on to anatomy now.
So the anatomy of the rotator cuff, we all kind of know, right? It's made up of 4 muscles, right? Your supraspinatus, which is primarily used for abduction, which was really interesting when I was looking at it. It was like in the Gray's Anatomy text, it actually said like it could basically do abduction without the deltoid.
Oh.
That was crazy. I was like, no way. But yeah, so it is a powerful abductor.
Which why when it hurts, it's so sucky.
Yes. Then you have the infraspinatus, which performs external rotation, subscapularis, which performs internal rotation, and actually some weak adduction. I didn't really consider that, so think about that, especially like overhead, and you're bringing that arm down, right? Some little adduction there as well. And then teres minor, also internal rotation. Or wait, no, external rotation. I'm sorry.
Yeah, I was like, hold on.
I wrote it down. I reversed them on my notes. So teres minor, external rotation. What was interesting too in the Gray's Anatomy text as well is they actually brought up the role that teres major. I mean, we don't ever really consider it a rotator cuff, but it actually does when your arm goes overhead. It actually does serve a role in stabilizing the humerus within the glenoid, which I feel like we never really talk about. So I thought that was kind of cool. It kind of supports that antero-inferior aspect of the joint. So
I feel like no one talks about the teres major.
Which is weird because it has major in its name. We talk about the minor one.
teres minor.
Yes, I like the jingle to that one. So those are the individual functions of each rotator cuff, and obviously the name rotator makes you think like, oh, it's going to rotate things. But really, the big job and the really sole purpose of the rotator cuff is all together, they basically keep the head of the humerus inside the glenoid.
Mm-hmm.
And really a big role of that is trying to overcome the elevation of the humeral head that could be caused by the deltoid, right? Because if you look at kind of how the deltoid's shaped and where it's at, the line of pull would basically make that humerus like jam up into the acromion, which, kind of looks like, fist bump at the club, but your tendons and bursa and stuff like that under there don't want that. They're just going to get jammed.
They're not club people.
They're not club people. They don't like the crowdedness of it. Right, so we need the rotator cuff to help really control that and keep that humeral head centered so it doesn't kind of migrate upwards.
In your readings, was it ever discussed about force couple, like upper trap, lower trap, serratus anterior?
There was a brief discussion on it, just about how they kind of react with the scapula, and we'll talk a little bit about scapular motion as well.
Okay,
I feel like you
perfect.
can't talk rotator cuff without talking
definitely
scapula. So kind of like what we alluded to. Right, within this area of the shoulder, there are a lot of structures that are just chilling in there, right? And that is really referred to that. We're really talking about that subacromial space. So just under the acromion process and just superior to the humeral head, there's that tight little space where you have the supraspinatus tendon, subacromial bursa, long head of the biceps tendon. Essentially, very crowded.
Mm-hmm.
And if you're like me, crowded bars, crowded clubs is too much. Right, so a lot can go wrong in that area. And that's what the tendons say. They're like, hey.
They're a little antisocial.
Well, especially when someone's fist bumping at them. Then they get really antisocial. So kind of like what we were already started kind of previewing is we can't talk about that rotator cuff without talking about the role of the scapula and some of the muscles that stabilize the scapula. All right, so some of the important players here are one, the upper trap, which the upper trap really serves a big role in elevating the scapula. So that kind of like, elevation. Mm-hmm. Then you have your middle trap, which is really good at retraction, especially when it's paired with the rhomboids. It does a really good job of retracting the scapula. Your lower trapezius, which is really big in upward rotation. Your pec minor, which does protraction and downward rotation of the scapula, right? If your arm's up, scapula's got to come down somehow. And then we have your serratus anterior, which again does protraction and also upward rotation. All right, so again, there are force couples there between
the upper trap, lower trap, serratus anterior.
Yep. Yeah, exactly. So all those work together to create nice smooth motion of the scapula when our arm's starting to go overhead. I can't remember the scapula. Was it the scapulohumeral rhythm, like the actual numbers? But there actually has been some research I heard that's actually calling that into question, that it's not super defined.
Yeah, I heard about that too. And also I feel like I've recently heard more about how impingement's kind of been called into question.
Yeah.
The way that we have thought about it up until now.
Yeah, for sure. Right. So, and I think that's one important thing is humans in general, we just move differently.
Right.
Right. Everyone's going to move slightly different than someone else. So it's probably really hard to kind of define like, oh yeah, this is how your scapular rhythm should be. Because some people could probably get away with it and not have any issues. Just like those people that have pes planus and their like arch is like below the ground somehow. And you ask them like, does that hurt or do you have any pain? They're like, no. It's like, oh, well,
or
my
like
eyes hurt.
Extreme lumbar lordosis and they have no injury.
And no issues.
Yeah.
All right. So all those muscles are going to play a role in the rotator cuff tendinopathy because they act on the scapula. That means they're really going to have an influence on that subacromial space where those tendons and all those structures lie, and hopefully help kind of keep that open so everyone has some room, right? It's like being on a plane, right? You don't like being crunched, right? You want some leg room. That's what the scapula stabilizers are going to do for us.
Especially because the shoulder has so much motion. And
Yes.
the joint itself is just not like really any other joint in the body.
Yeah, that's true. It's highly mobile.
The articulations are just crazy.
And the amount of force, I think, or like the amount of motion, like you said, like I think it can produce 7,000 to 8,000 degrees per second of rotation. That's crazy. No, nothing else is doing that.
No.
So now that we kind of discussed the anatomy, kind of setting that foundation of what we're kind of looking at, now it's important to talk about some actual risk factors that could kind of like lead someone into rotator cuff tendinopathy, and then also dive into, now you have someone with shoulder pain. What do we do to maybe rule it in or rule it out?
Mm-hmm.
So essentially, rotator cuff tendinopathy definition seems pretty obvious, right? It's just irritation to the tendon of the supraspinatus, and it's particularly the supraspinatus. So if you really look at the literature that talks about rotator cuff tendinopathy, they're really focused on the supraspinatus. So they're not really looking at like infraspinatus or subscap. At least I didn't. Everything I read literally focused on that.
Interesting.
Yeah.
I feel like I've seen both supraspinatus and infraspinatus involvement, at least like MRI.
I wouldn't be surprised, but yeah, for some reason, when you look, like if you pop this bad boy into PubMed, most of those articles are focused solely on supraspinatus.
Interesting.
Which again kind of makes it tough to find it in the literature, but another reason it's hard to find those articles is because it does get looped in with the umbrella term of impingement syndrome or subacromial impingement.
Right.
Which again, we've shown that it's really easy. A lot of different pathologies get thrown in there. And then a lot of studies that look at like risk factors or interventions sometimes just do generalized shoulder pain. It's like that could be anything.
Yep.
With it being a tendinopathy, irritation to the tendon, essentially what you see is just a failed healing process for the supraspinatus tendon. So basically, there was some trauma, tendon slightly irritated, body tries to heal it, but then guess what? Because it's athletics and it's really hard to kind of adjust time. You're always constantly going. It happens again, and now the healing process just hasn't gotten a chance to really set hold and actually start repairing the tendon so we don't have pain. And then as that progresses, right, that's where you can start running into different issues of, okay, if the healing process fails, you go to like tendinosis, degeneration, and then eventually that could turn into a full, like kind of partial or full rotator cuff tear.
I wonder if the rotator cuff tears are more present in people who have had these tendinopathies while they were younger.
Ooh, that's a good question. I would wonder, because I didn't focus on that. I didn't really see that.
Mm-hmm.
But I would wonder. That'd be interesting.
Well, it makes sense because most of them are from chronic degeneration, right?
Yeah, chronic degeneration. And then also a lot of like kind of that older population tends to get rotator cuff tears, which we know tendons don't heal as well as as maybe a younger athlete. So I could see that.
Mm-hmm.
Yeah, good point. Yeah. That would be really interesting to see if they've had a history of tendinopathy. That kind of leads into actually the risk factors, because we all know previous history is a pretty good predictive risk factor,
right,
for future injury. But they also looked at some other different elements, and kind of like with other pathologies, these tend to be kind of limited and a little bit weak on how good they are at predicting the risk of injury. There's some evidence that shows weak external rotation and weak internal rotation, right?
Mm-hmm.
So if you just have weak rotator cuff, they can't really support the tendon very well. You're going to run into some issues. Basically, it's like those signs that you see on the roadway that says soft shoulder. Soft shoulder if it's weak. We had a road trip where I saw that a lot, and I was dying laughing.
He was very excited about them.
And that's fairly limited data, but there's even weaker data that says maybe a decrease in the external rotation, internal rotation strength ratio. So if you have stronger internal rotators compared to your external rotators, that could also be an issue.
Like general imbalance.
Yeah, exactly. Like just a general imbalance. Yeah, usually imbalances are pretty bad.
Yeah.
There was some stuff that looked at range of motion. Again, it's kind of weak, but lacking external rotation range of motion, which it was about 106 degrees of external rotation.
What's normal? I feel like that sounds like a lot.
I think it's kind of looking at like athletics, like upper extremity athletes, because they should gain more compared to like probably what normal would be, like 90. Mm-hmm. In like a general population. So that might be where it's coming from. I think that study did particularly look at athletics and actual upper extremity athletes.
Interesting.
And then, like I said, there's a lot of stuff that has looked at risk factors for just generic shoulder pain, which now you're like, what does that mean?
Right.
Like, what pathology are we talking about? So if you kind of look at that, you could add in GERD, right? So if you have someone that has GERD, right, they're probably going to have a higher likelihood of possibly rotator cuff tendinopathy, definitely probably shoulder pain. And then again, training load could also be a factor, which I think that's a big one. I think if you have like a weak rotator cuff and then you add in training load and it makes it more fatigue, now you're going to run into issues. So I think training load is a big one. So the swimmers that have 3 practices a day and they're like swimming miles, that's tough.
Right.
And of course, like I said, history, that's a big one.
So what do we look for when we're evaluating these tendinopathies?
So a lot of it, of course, is that history that we'll take, right? See if they've had shoulder pain, but also kind of getting an idea of when they have pain. And it's really going to be a lot of motions that kind of compress that supraspinatus tendon or maybe add a little too much load to it. So I think that's really going to start, they'll get it. I think there was reports of pain between 60 and 120 degrees of abduction or abduction in the scapular plane.
I'm just testing my ouchie shoulder right now to see if that's the arc that I'm in pain with.
See if you have painful arc. Right, so they may have it there, right? Or even like going cross body and in elevation, right? That's gonna
definitely have pain with crossbody.
Yeah.
Yeah.
Right. Anything that's really gonna cause that kind of like theoretical impingement might be causing it, or like if you're trying to load abduction.
Right.
Overall strength should be pretty much preserved, right? If it was a tear, you would see probably more weakness, but I think the weakness that you may feel could be painful, right? So like if it hurts, you're like, oh, I don't want to do that anymore. No, thank you.
Right. Are we using just normal special tests for these, or?
Well, that's what I was going to say. Now it's always time for the fun part, special tests of the shoulder.
That is not the fun part for me, but okay.
Everybody loves what, all 200 or whatever insane amount of special tests for the shoulder that aren't very good.
Don't even really tell you much.
Yeah, aren't very good at all. Yeah. There are 2 that, one, tend to be used a lot in the literature when they're trying to confirm someone with rotator cuff tendinopathy to put them in like different groups. They do the clinical test and like ultrasound, so you can at least guarantee like, oh yeah. Hawkins-Kennedy, right, is one that gets used a lot. That one's pretty basic. Sensitivity of 83%, specificity of 69%. So theoretically, it should be good at ruling it out, right? So if Hawkins-Kennedy doesn't hurt, you're like, oh, okay, probably don't have it.
I know we just knocked shoulder special tests, but I actually really do like Hawkins-Kennedy.
I've used it more and more lately. So I've noticed, especially because it's so easy, because I could do it when they're laying down and like have them here and boom. As with all my other shoulder things.
Yeah. And it gives you a lot of information because you don't just have to test in one spot. You can like test it like in front of you. You can adapt it and you can test like in scaption.
Yeah. Positive likelihood ratio 2.68. Negative likelihood ratio of 0.25.
Can you review again?
Yeah, I was just going to kind of say that positive likelihood ratio, I believe, is really small. I think really good is closer to 10. So that just tells you we're way off on the positive likelihood ratio of that meaning anything. The negative likelihood ratio of 0.25, I believe that's pretty good. The next one is painful arc test, right? We already talked about kind of a report of them having pain between 60 and 120 degrees. That is basically a positive painful arc. They're looking for pain at 60 to 120. So positive likelihood ratio of 2.68, negative likelihood ratio of 0.25. You want your positive likelihood ratio closer to 10. So 2.68 is pretty far. So not great there. And then a negative likelihood ratio, you want it less than, a perfect world would be less than 0.1. So it's getting close. So it's pretty good about that whole, like, hey, if it's negative, you can feel pretty good that you don't have the condition.
Like a negative will be correct.
Yeah.
Not having the condition.
Correct. It for sure would rule, or you feel strong that it's going to rule it out.
Positive is also that it's positive, right? So basically likelihood ratio is just correctness.
Yeah. Yeah. How is it actually?
Accurateness.
Yes. The next one is painful arc, which again, like in that motion of, oh, you have pain somewhere between 60 and 120. That's basically a positive painful arc. This is done in abduction. Sensitivity of 62%, specificity of 82%. Again, if we look at the likelihood ratios, positive likelihood ratio 3.44, still not close to 10. So not that great at ruling it in if it is positive. And then the negative likelihood ratio is 0.46, still not great also.
That's decent.
Yeah. There is some stuff that's kind of looked at like maybe using a cluster, but there really hasn't been examined in the literature that much. So it's really hard to say like, oh, is it truly good or not? But it is something to keep in mind. And it's basically 3 out of 5 positives for the following tests. That's Hawkins-Kennedy, NIRS, empty can, which also could be referred to as Job. I forgot that was called Job's test.
Yeah.
So if you're reading literature and you read Job's test, you're like, well, what the hell is that? It's empty can. Painful arc, and then external rotation against resistance.
I feel like that's all your impingement tests and your like range of motion.
Supraspinatus specific, right? Yeah. Positive likelihood ratio, again, 2.93. Negative likelihood ratio of negative 0.34. So again, it kind of doesn't really perform that much better than individual tests alone. But I do like the idea of clustering them. So it would be interesting to see what that looks like as maybe more literature comes out on that kind of cluster.
Sweet. So let's talk about management.
Yeah. So now that we've identified it and we've said, yeah, your rotator cuffs poo-poo.
Censored version. Yes, that.
Yeah. Now we go to the management. It's again, management for rotator cuff tendinopathy follows pretty much all tendinopathies. We're going to rehab, right? There's going to be some kind of rehab. And as with any tendinopathy, loading the tendon is what triggers that healing process and helps get the body to be like, oh, hey, we got to fix this. But what's really interesting is for everything that looked at the rotator cuff, or at least supraspinatus in general, was there wasn't really a huge difference between eccentric and concentric work, which is pretty crazy because like a lot of stuff for the lower extremity says, oh yeah, blow that up with eccentrics, right? There actually really wasn't that much of a difference. Like it was, I think like statistically there wasn't, but there was maybe like slight differences that pushed towards like, hey, eccentric might be better. But statistically it wasn't that different. There's even some stuff that has even looked at like going into just isometric work, which if you're familiar with McKenzie method, which most people think of that, oh, that's a back,
like lower back.
Yeah, that's a back thing. They do actually have stuff for like the extremities. And basically their method targeted isometrics, right? You find a spot, oh, it hurts here, and then do the isometric there, and eventually that should.
I use a lot of isometrics in my rehab for tendons.
Yeah.
Especially in the beginning, because I feel like getting that load and getting them comfortable with that load before I introduce eccentrics can kind of also help with buy-in.
So that's actually what I was leading into was, I feel like that's a great way to start, especially if it's already painful, right? Because no one wants to just sit here and just do eccentrics and get blown up and then you hurt. Right. That's one limitation of it, is sometimes it's really painful. So compliance tends to be low.
Right.
I'm a big person that believes in, I would rather them do something for it, like get something out of it instead of not do it at all. Right. I'd rather get something. So if concentric is what they're going to be able to do, and I know they're going to get that done, or isometrics, we're actually going to be able to get exercises done, I'd rather do that than try eccentrics. And then they'd be like, this hurts too much. I'm done. I'll just thug it out. Right. So that is one thing that I think that's a good place to kind of maybe start formulating your rehab process is, okay, how painful are they? Right. If they're really tender, yeah, maybe isometrics is a great place to start. If they're not super tender, but they're kind of like, it doesn't feel great, maybe concentric. And then you eventually progress that into, hey, they're feeling good, they're getting stronger, then do your eccentrics. I think a combination of that is a nice sweet spot.
What about like loading?
That's another interesting thing, because again, there's a lot of stuff now coming out for tendinopathies that, hey, you want to load the tendon, which eccentrics do well, but you could also just put a lot of load on it, just like a lot of resistance, and that should be loading the tendon. And for the lower extremity, there's a lot of good stuff that high load, slow, controlled contractions may actually be more beneficial than eccentric, or at least be about the same. But in the upper extremity, they're really, again, statistically not a huge difference. Again, statistically, right? Now, if you looked at the actual numbers, like maybe high load kind of has the edge, but statistically it didn't reach significance. So use that with how you will, right? Because again, we're not treating means, we're treating people. So
I love that quote.
Thank you. So again, high load might be good for your individual patient, right? It's shown some benefit in lower extremity tendinopathy. So theoretically it should be about the same here. So feel it out with your patient. But that's what kind of the evidence says. It's shouldn't be that much of a difference, but like I said, it could.
I feel like also depending on the athlete that you're working with or patient or whoever your person is, I feel like sometimes you get the athletes, especially like my population, like if I do something that they're not feeling, they think it's not working.
Yeah. Yeah,
so
I agree with that.
Sometimes the high load, even though like it's not necessarily following like, oh, this is the absolute best thing you need to be doing via the literature, it might be the best thing, like you were saying, for that person.
Yeah, exactly. That's one big thing. Like, I rather them do it, like what they're doing, than like, oh, I hate this, and then they're not going to come back, and then what have we done? Like, they're just going to...
Because sometimes they're like, if it's harder, they're like, oh, like I'm working towards something.
Yeah. No, yeah, for sure. I think one thing too that's a kind of a confounding factor that, like, again, in a study, like sometimes you can't do, especially if you're looking at one thing, is the application of scapular exercises. Right? We're not going to just like, oh, here's a couple, do your rotations, and that's it. Right? We're always going to try and throw in something in there, especially if when you're doing your full eval, like how does that scapular motion look, right? Do we have like, are they growing wings? Because like there's so much winging, or, you know, so that's one thing, is applying scapular exercises. And there are studies that support that those with rotator cuff tendinopathy do have abnormal scapular kinematics. There's increased upper trap stiffness. They show decreased upward rotation motion.
And that upward rotation is upper trap, lower trap, serratus anterior.
Exactly. Right. So if there's a dysfunction between any of those, that's going to cause issues there.
Couple, that's usually where I start, honestly.
Yeah. And again, that whole upward rotation is what creates the space for your arm to get up here without crashing into tendons.
And most of the time, it's upper trap high activity and lower trap low activity. And no one wants to rehab their lower traps.
No.
So incorporating that into rehab is probably one of the first things I do too.
Yeah, absolutely. Because again, this is people who have the tendinopathy. So this is their movement pattern when they're in pain.
Right.
Right. So again, these studies that looked at it, it's hard to say which one came first. Right. But again, from a rehab standpoint, well, I know this person has pain. I know they're going to have these abnormal motions that I need to correct.
Right.
What was interesting is there was a study that tried to look at like eccentric exercise and how does it compare to like concentric exercise. But what was interesting, the eccentric group just did eccentrics and stretching. The concentric group did concentric, scapular exercises, and stretching. And what was interesting is the group that did the concentric, that also paired the scapular exercises, performed the same as eccentric group.
Oh, that's good.
Which again, when you think tendinopathies, you're like, oh, well, eccentric theoretically should have been better because of all the other studies that have looked at eccentrics and tendinopathy. But you add in the scapular exercises, look at the benefit that you get from it. And I think it's because you're addressing poor movement pattern too. So keep that in mind when you're prescribing those exercises. Again, if you have someone who's like really painful with the shoulder, shoot, that might be a good spot to start. Hey, we'll just focus on the scap, do some isos for the shoulder, and then there you go. So I still think that's productive.
Right.
So yeah, I would say definitely kind of pair in scapular exercises with your shoulder work. In particular, you really want to focus on that lower trap, middle trap, serratus. There were some studies that showed when those have, it's kind of obvious, but when those have good strength, good activity, subacromial space opens up more.
Look at that.
Weird, right? Another intervention that gets talked about, and I think is fairly common within athletic training, especially for treatment for the shoulder, is taping. A lot of times people like do the posture stuff. And there is some evidence that it might be able to help open that subacromial space. So again, that's another thing that we can use to help hopefully give some pain relief, train some like activation, like some actual motor control.
Are you talking about like KT taping?
Most of it's KT tape.
Okay.
They looked at rigid taping, but that was kind of like to actually open it. It seems like the KT tape was a little bit better.
Again, KT tape paired with rehab, not just KT tape, take KT tape.
Yeah.
Because that's not going to do anything.
Correct. All right. So yeah. So there is the potential for that to actually help open up that space and kind of have a little bit of pain relief in conjunction with your rehab.
Sweet. Do you have an action item for this? I have one.
Oh, go for it.
Do your lower trap exercises.
And then I will say, really tailor your rehab for this to your patient, right? Get what they're feeling, right? If they feel pretty good, you could probably load them a little bit more. If they're feeling pretty bad, maybe start a little bit lighter on the load, but still trying to load the tendon. That's what I'd say. And do your lower trap exercises.
Yes. One that I really like is I lay them prone. I put them in I put a foam roller at the edge of the table just under their wrists, and I place their hands on the foam roller and with their thumbs to the ceiling.
Okay.
And then they keep their head facing towards the table, and all they're doing, this is the hardest part for them because they want to lift up, like they want to lift their chest off the table.
Yeah.
Their chest stays on the table. All they do is roll the foam roller towards them and then roll it away. Literally, it's like 2 inches, but it just starts the activation. Think of like, you know, when you're hanging on a pull-up bar and you just do like a scap pull-up, just like that, but you're doing it on the table and it's just starting that activation. It's almost like your eyes wise tease, except that it's for lower trap.
That's interesting because I do one very similar. I'll lay them prone. I fold a towel that they basically, I have to preface this that like, hey, when you do this exercise, you're gonna probably feel stupid for doing this, but it's great exercise. I fold the towel and basically they lay on the table prone with their forehead on the towel. So literally their faces in the table. So they feel weird about doing it. Arms will be to the side and then same thing, right? I'm having them basically drop the shoulder blade down and then retract.
Oh, good.
Right. And so I try to show them too. So when they're laying down, I'll have my hand on their scapula and I just basically kind of show them the motion that I'm going for. And then they do it. Then they'll perform it. And then I also check upper trap to make sure it's not firing.
Yeah.
And then once they're able to do that on their own, I kind of let them go. They usually get really jazzed when they come in for the treatment, and that's going to be one of the exercises. I get the towel out and I fold it like, oh no. I'm like, what are you talking about? You love this exercise. Don't do that.
Yeah, one of the cues I use is shoulder blades in your back pockets.
Oh, that's a good one. I like that. I didn't think of that one. I like the foam roll one. That's kind of cool.
Yeah, I like that one too.
That's pretty dope.
That's usually my go-to start with the eyes wise tease. Actually, I don't even do eyes wise tease. I say eyes wise tease because that's what it's called. I mean, that's what everyone calls it, but yeah. I really only do eyes, T's, and W's. I don't really like Y's because I feel like Y's, most people have so much upper trap involvement.
That's the problem, yeah. Because Y is supposed to be really good for lower trap, but the problem is, yeah, if you don't have good control, that upper trap does it.
This is, I mean, the foam roller one I do is basically like Y, but instead of like a shoulder flexion, I guess I'm just mostly going into scap retraction or a scap depression.
Yeah, but no, that's true. That technically is a Y because you're here and doing this.
Right.
Yeah.
Boom. So again, you can get your CEU certificate through clinicallypressed.org. All of the information is down in the show notes below. We also have a tutorial on our Instagram pinned to the top, so you can watch us go through the process. Again, if this is in our latest 5 episodes, it is a free CEU. If it is not within our latest 5, it is purchasable. The proceeds go not only to the show, but also towards donating ice tubs, which is obviously super important. Yes. So Clinically Pressed and Athletic Training Chat do a really awesome job with that, and they give back a ton. So make sure you check out their other stuff too, because they're really awesome. We also do other episodes here on AT Corner, not just CEUs. We do story episodes where we bring stories from athletic trainers from all over the world to come together on a topic of whatever we want to talk about that week. I think upcoming we should have some imposter syndrome stories. We got a request for that, so I'm going to start to be putting together those soon. I haven't started yet, but if you have any stories for imposter syndrome, send them our way. If you want to get notified of when I send those story prompts out, join our broadcast channel, which is also on our Instagram. It says submit your story, and you can join and you will never miss a story episode, because we don't send messages that often, but when we do, we just say, hey, our prompts are up, come send us messages. And then lastly, we also do interview episodes, and we do BOC IRL episodes. So if you're studying for the BOC, or if you just want a good review, you can tune in for those. And those are sponsored by AT Study Buddy. And I think that's all I have.
Thank you for helping us showcase athletic training behind the tape. Bye.